failure with preserved ejection fraction and obesity. Basically, heart failure with preserved ejection fraction, we diagnose with EF equal to more than 50%. Those having signs of increased LV pressures that may be seen on echo as non-invasive or based on elevated NT-proBNP levels. Third is heart failure symptoms. Most common finding being diastolic dysfunction, and where we do not find any other causes of preserved ejection fraction. Patient is obese. So, during obesity, the cardiac changes that we observe, first is the hemodynamic changes. Due to increased adipose tissue and free fat mass, there is hyperdynamic circulation. This hyperdynamic circulation increases metabolic demand, so that the cardiac cells uses more of free fatty acids rather than glucose utilization. That is one metabolic change that it goes on, which is maximum. So there are more number of oxidative stress. Increased blood volume increases venous rhythm, which leads to ventricular dilatation and wall tension. That is the most common cause of eccentric ventricular rebonding. Heart rate is normal or mild increase, but the major reason for cardiac output increasing is the stroke volume, which increases in proportion to body weight. So there is increased cardiac output, there is increased cardiac work and oxygen demand. So based on the time-standing relationship, increased LV pressure and volume shifts towards the left side, increasing myocardial oxygen consumption and widened atriovenous oxygen difference. So chronic overload leads to LV dysfunction and eventually failure. There is increased afterload due to aortic stiffness, mostly seen in hypertensive patients, which increases peripheral resistance. And increased afterload in case of right ventricle is secondary to LV changes, which is in the severe cases. So these are the hemodynamic changes. There happens alterations in the cardiac structure as well. The heart rate is increased proportionally with the body weight. Both eccentric and concentric LVH patterns are seen, and there were two studies which showed strong relation with LV mass with BMI, and LV mass increases with waist circumference and waist hip ratio. We see LA enlargement. LA enlargement is mostly due to increased LV pressure, and there is excess pericardial fat related to visceral adiposity. So basically, pericardial fat is a marker of visceral adiposity, which is mostly seen in RV, perivascular, and cardiac skeleton. So this is a cardiac MRI image in a lean patient. This is during end diastole. We can see the thickness of the cardiac wall is less absorption is low, viability of 80%, and peak dose peak concentration takes around 72 hours post injection. It's a widely distributed, highly protein bomb, and metabolism is by proteolytic cleavage and beta oxidation. Does not require CYP enzymes. Elimination is usually half-life is 5 days, so that is why we give weekly injections. And steady state of the drug is achieved within 4 to 5 weeks of weekly doses. Dose starts with 2.5 mg and it has to be titrated up to 15 mg once weekly. The adverse effect gastric are the most common: nausea, vomiting, diarrhea, constipation, abdominal pain. Metabolic adverse effects is the most common hypoglycemia when combined with insulin and metformin. Others are injection related and very rare is pancreatitis and gallbladder. Contraindication: in phase 1 trial in animal studies, it was shown that there was increased chances of medullary thyroid carcinoma. Hence, any person with personal or family history of MTC, multiple endocrine neoplasia, are contraindications for this injection, or those who are known to be having hypersensitivity to the receptor, or in those with gastrointestinal disease, we should be using it with caution. Pregnancy and lactation not recommended yet because we don't know the long-term safety and we don't have safety for the criteria for this also. So, Summit trial, it's a phase 3 trial, randomized, double-blind, placebo-controlled study, and the aim was to evaluate the efficacy and safety NT-proBNP level was actually less than 200. So all those patients that were included were not having high NT-proBNP levels, but there were other chances of other signs which were showing that it was elevated LV filling pressures. 6-minute walk distance average was 300 meters and HSCRP average was of 5. And most of the patients were on the normal heart failure treatment, and 69 of those patients were on SGLT2 inhibitors.
Class 3 and class 4 NYHA 28%. Generally heart failure, reserve ejection fraction માં NYHA class 3, class 4 overall કેટલા percentage હોય? Very less, right?
Very, until unless there are gross cardiac structure changes which have.
If it is not acute decompensated, then you will rarely find any reserved ejection fraction patient who is having class 4 NYHA. તો આમાં 28% ક્યાંથી લાવી આ લોકો? કયા પેશન્ટ છે?
Obesity main concern in factor and responsibility.
And what is the relationship of NT-proBNP and obesity? Will it affect NT-proBNP level?
Most probably વધતું હોય છે obesity.
એટલે વર્ષો સુધી કે છે એ લોકો up to 200 સુધી without any heart failure.
Without any
But only obesity is likely to raise NT-proBNP.
No, we'll do rather if I'm not mistaken. NT-proBNP falsely reduces.
Most of the patients
obesity falsely reduces NT-proBNP level. એટલે આ ઓછાવાળા બી આમાં લોકો રેન્ડમાઇઝ કર્યા છે.
I don't know.
Mostly it's like that.
most
That
of
is
the
what we are
patients
saying, even
has
if
less than 200 proBNP.
yes, the average was 169. So that is what they are trying to say, that they have included patients who are not having elevated NT-proBNP, which is the most common thing we see in a heart failure patient. So even in those patients, this drug was there.
If you do not consider heart failure, the dyspnea in obese people occurs due to other two reasons. One is obstructive sleep apnea syndrome, and another 38 BMI હોય તો obstructive sleep apnea component હોવાનો, and another thing is obesity hypoventilation syndrome. એટલે હવે એવું બધું તો અંદર આવ્યું નથી, પણ 38 BMI હોય તો obstructive sleep apnea હોવાની શક્યતા વધી જાય છે. કદાચ એના લીધે dyspneaનો પેલો NYHA ક્લાસ.
But they are saying that we have excluded patients with other causes of dyspnea. And OSA, COPD, able to exclusion criteria.
પણ 38 વાળાને
NYHA
38 BMI વાળાને I don't know.
NYHA નો ક્લાસ તો ઓન્લી પેલા એના ઉપર ફંક્શનલ કેપેસિટી ઉપર બેઝ છે, તે કદાચ એ તો તમારું આવી શકે ઓબેસિટી.
Next slide આગળ વધો તો.
Third and fourth માં fourth નહીં હોય, mostly they would be third.
હા, so એને third and fourth બહુ જબરદસ્ત રીતે ક્લબ કરીને આપી દીધું.
Yeah, because fourth is basically on rest. That happens when the patient is completely debilitated. Third is that original baseline activity is reduced, so that most of the obese patients will have that problem.
See, third also is also very high level of dyspnea, right? Even if your BMI is.
That, but it's a functional assessment. If I'm going to ask you, you're going to say yes.
So third is you cannot perform routine activities without difficulty,
Yes.
right? You don't toilet ના જઈ શકો, મારું brush કરવા ના જઈ શકો,
That
right?
is less. But
So
if,
એવા બી 28% is very high.
but if the baseline BMI is of 30, that person is obese, is going to definitely say I'm not able to have a proper.
Yeah, that is class 2 હોઈ શકે. Class 3 generally ના હોય. તમે એવું obese હોય ને તો routine activity તો કરી લેતો હોય. Unless super high BMI, જેનો 50, 60, 65 BMI હોય, 180, 170 kilos હોય, right? હવે next slide બતો જરા. We don't have any echo finding here, no?
No, sir. Echo finding basically हमने ये कर जो either NT-proBNP or echo findings of LV filling, increased LV filling pressure. They have no, the sub-study includes our sub-study that includes cardiac MRI imaging on the fat mass. But echo findings include echo makale to EF. EF is more than 50, it's preserved.
So LV filling pressure કઈ રીતે મળે?
Non-invasive
echo માં જ ગણી હશે તો એને ડિટેલ લખ્યું હશે.
That is what is echo. But they are not specified that who is having LA enlargement or who is having raised, there is mitral regurgitation
ટ્રીટમેન્ટ બી છે એટલે આ લોકો
हाँ,
ટ્રીટમેન્ટ
HF
લેતા હોઈ શકે
treatment
that
पर भी
might
ये
be
चीज़ों એવું નથી કે only this drug is eating the soul.
એટલે એમાં બધી જ હાર્ટ ફેલિયર માટેની મેનેજમેન્ટ લખેલી છે ડાયાબિટીક
DAPA is
એસજીએલટી
class 1 recommendation of if that patient are already on SGLT2 inhibitor. So we don't.
આમાં શું unscientific point થયો? Suppose when this trial was published, it's published this year only, right? અને I guess 22-23 માં start થયો હશે. During 22-23, heart failure with reserved ejection fraction had already SGLT2 inhibitor as a class 1A recommendation. The only drug which was there is a class 1A, right? હવે આમાં ખાલી 19% ને તમે SGLT2 આપ્યું છે.
Yes.
Ideally 90% should be at least on SGLT2
They should
inhibitor.
be on it. એટલે
Right, so
one
હવે
of
તો
the-
આ રિઝલ્ટ તો બધા how you will implement this કદાચ આ પોઝિટિવ આપી બી દે તો
એટલે that is one thing.
સાથે સાથે પેલી એમઆરએ બી આવી ગઈ છે અંદર એડ થઈ ગઈ છે એટલે એ બી
એમાં 36% વાહ આવો કયો પ્રાઇમરી ઇન્વેસ્ટિગેશન છે જે રિઝર્વ ઇન્જેક્શન ફ્રેક્શનમાં એમઆરએ 36% માં આપ્યા અને એસજીએલટી 19 માં આપ્યા
8%
કેટલું હાઈ લેવલ છે એટલે તમે
આ તો
યુઝ કરનાર
મતલબ this is aligned driven trial.
The results, the primary endpoint, the incidence of cardiovascular death or worsening heart failure was 9.9% in Tirzepatide group, 15.3% in placebo. The hazard ratio came out to be 0.62, so basically 38% reduction in the chances of having worsening heart failure was seen in Tirzepatide, and it was p-value significant. So this was the first primary endpoint. Second primary endpoint was change in baseline of the KCC score. So Tirzepatide had 19% of change in the score compared to placebo, that was 12.7%.
See, એક સ્લાઇડ પાછળ જાઓ પાછળ તમે આજે કપલાઈન વર્ડ ગ્રાફ જોશો ને તો આમ તો સેપરેશન 24-32 વીક આસપાસ ચાલુ થાય છે પણ સિગ્નિફિકન્ટલી 40-48 વીક પછી ઉપરમાં એટલીસ્ટ ડિફરન્સ આવે છે નીચેમાં તો એટલો ડિફરન્સ આવ્યો બી નથી તો વોટ ડઝ ધીસ સિગ્નિફાઈઝ
Basically,
ઓલમોસ્ટ 6-8 મંથ સુધી તો તમને કઈ there is no advantage at all. It's the whole of both a placebo and બંને goes in the hand in hand, right? Right. So
if you're not doing anything, the person who is obese is eventually going into heart failure.
no, it's આ તો બેન આખું અલગ છે. See, તમને ફાયદો ક્યાંથી થાય છે એક ક્વેશ્ચન છે કે તમે રિઝેબેટાઇડ પર મૂકી દીધા then when you will expect કે આ પ્રાઇમરી એન્ડપોઇન્ટમાં તમને ઇમ્પ્રુવમેન્ટ થશે આ થશે વાં થશે after 8-9 months of that classically suggest that the drug is not working at all on the primary pathophysiology.
it might be because of the it reduces obesity
Exactly.
it might be reflecting it
Right કે જ્યારે weight loss થશે પેશન્ટને ઇમ્પ્રુવમેન્ટ થશે ત્યારે એને ફાયદો થશે 8-9-10 મહિના પછી.
these effects
That
may
is
be because of
the
the
drug
real
is trying to say that reducing weight, due to the reduction in weight, there are changes in the
Yeah.
cardiac. The drug is not stopping
Exactly,
cardiac
right.
thing, it is just basically
હવે
reducing.
આ જ વસ્તુને તમે if you have seen the data of credence or EMPA-CKD or DAPA-CKD trial, you will see that in 2 to 3 weeks or maximum 4 weeks the CKD endpoints start separating as far as SGLT2 inhibitor are concerned, right? So this is the difference when you interpret such graph.
This is the table. In that basically the major chunk of decreasing in first primary endpoint was there is reduced worsening heart failure events. So approximately 8% of the patients had reduced incidence of intravenous requirement of hospitalization or intensification of the oral therapy. This is that table. And for secondary, change in 6-minute walk distance was approximately about 26 meters in the drug group. Percentage change in body weight was approximately 14%, and HSCRP level reduction was also approximately 38%. The change in body weight in HSCRP was both significant values. The NT-proBNP values did not show much changes.
practically no change
No change. Systolic blood pressure reduced by 4 mmHg. That is one thing they have correlated. So these were the secondary endpoints. So body weight had decreased HSCRP level, which showed there was less systemic inflammation. So the inflammatory effects was less on the cardiac side. Reason being possible dual receptor effects that decrease adipose inflammation and myocardial fibrosis, as well as additional anti-inflammatory impact on epicardial fibrosis.
See, yeah, I was cooking. What was your baseline HSCRP? It was 5 point
5.
something, right? 30% reduction into 3.55.
Yes.
What the hell difference it will make? Nothing.
But sir,
But theoretically, you find decrease adipose inflammation.
HSCRP normal value, like now it is like low risk are less than 2.
Less than 3.
Less than 3 and then 3 to 5.
हाँ तो 5 માંથી 3.5 થઈ તો કેટલો ફરક પડી ગયો?
HSCRP ઓછું કરે છે ઉપર. And same thing, benefit was consistent even in patients with low NT-proBNP level. So it basically tries to tell that if we diagnose based on only NT-proBNP levels, we may miss certain cases of heart failure. Unlike earlier trials, Summit did not require elevated NT-proBNP levels. In obesity-related HbF natriuretic peptides may remain low despite
બરાબર છે તમે ફિટ જે કહે it may remain low
increased
despite
cardiac filling pressures and significant functional improvement. Mechanism, I don't know. So baseline findings were that even yet patients, what they wanted to say that in baseline findings, even with patients less than 200 NT-proBNP, they had marked symptoms and 50% had prior HF hospitalizations or IV therapy in past 12 months. This trial was compared with STEP HFE trial for semaglutide. In semaglutide trials, the inclusion criteria had NT-proBNP twice the level which has been used in Summit, and higher rate of prior HF events are seen in Summit because the criteria has been come down, so more patients are considered as patients with HF. Limitations was eligibility was limited to BMI more than 30, which excludes lean patients with HFEF with visceral adiposity. Low NT-proBNP threshold may limit compatibility with other trials. Their classification included undetermined cause as well, so there was potential overestimation that was the same. Long-term cardiovascular and mortality effects required for the study. Another sub-study of this was Summit CMR. This was triazepatide reduces LV mass and pericardiac adipose tissue in obesity-related heart failure. So usually obesity is accompanied with increase in epicardial adipose tissue, which acts as a paracrine manner secreting pro-inflammatory cytokines. It extensively compresses the heart and impairs filling, and it reduces secretion of natriuretic peptides. Concentric hypertrophy resulting in increased LV mass is also more severe in obesity-related HFA. The objective of this sub-study was to examine the effects of the drug on cardiac structure and function with the underlying hypothesis that it could reduce left ventricular mass and epicardial adipose tissue. Methods were like basically a total of 175 patients from this parent study were taken, which were 1:1 randomized to either drug or placebo. A total of 106 patients completed the CMR study and had adequate image quality analysis for LV and left atrial structure and function, as well as pericardiac adipose tissue at both baseline and 52 weeks. So the key measurements was LV mass, pericardiac adipose tissue volume, epicardial plus pericardial, and correlation with changes in body weight, base circumference, blood pressure, and LV-LA volumes. The primary endpoint was LV mass. Secondary endpoint was epicardial and pericardial adipose tissue, LV-LA volumes, and LV-LA strains. So 175 patients were taken. Among them, 58 had missing data. So 107 patients were followed with another loss of 11 patients. So total 106 patients were included in the analysis. The primary endpoint, LV mass, there was reduction of 11 grams. The average reduction in LV mass was seen as 11 grams.
increased.
Not significantly.
Still increased.
This was a correlation of a change in LV ventricular mass and change in the patient in weight in baseline. So those with more weight loss had reduction in LV mass, and those with higher weight had less reduction in the LV mass. This was the correlation they had found with correlation factor 0.34 and significant p-value. Results in LA structure and function, no significant LA structure or function was found. There was no change in LA systolic volume, there was no change in LV volume, there was no change in LA diastolic volume. Even LA strain had no changes, no significant was seen. Third was in paracardic adipose tissue. It had shown that paracardic adipose tissue had reduction of around 45 mm. So this was the second point that was significant. Epicardial tissue as such did not show much difference. Pericardial adipose tissue had shown 43% reduction, which both combined as paracardial adipose tissue had shown as 45% of reduction. So this is basically a cardiac MRI image they had shown. So this red arrow signifies the pericardium. The black arrow is the pericardial fat that is seen. In 52 weeks, this has been reduced, but not to much extent. What we see in placebo is that this pericardial fat has increased to a great extent at 52 weeks. So major findings was decreased LV mass and decreased pericardic adipose tissue volume. There was no difference in LV diastolic volume, LV global or regional strength, LA volumes, function or strength. Reduced LV mass was correlated with reduced body weight. So this was the first study which was showing LV mass reduction with dual GLP GLP-1 RA therapy. LV mass reduction of 11 grams was compared to the STEP trial, it was only 4 grams reduction. So maybe that was due to in STEP of trial measurement was by ECO and as well as maybe there is a potential added effect of GLP. The mechanistic interpretation is that pericardial fat is a marker of visceral fat burden. So decrease in pericardial fat reduces pro-inflammatory, pro-fibrotic signal, reduce extrinsic restraint to LV, improving filling dynamics. No change in epicardial fat volume, but possible that there is improvement in biological activity which was not visible on imaging. So the limitations were that only 33% analytes had inadequate CMR images for analysis despite similar protocol. They did not measure extracellular volume. Extracellular volume is basically the volume that signifies interstitial volume, fibrosis, any filtration of amyloidosis of fat. That was not measured. So we don't know that the drug is actually reducing cardiomyocyte hypertrophy or it is reducing fibrosis. It is a bulk. And LG imaging was also not done. Rate gadolinium enhancement is basically for knowing myocardial perfusion. So that was also not mentioned. And RV structure and function was not analyzed. So only the focus was on mass and pericardial. Basically to conclude that summary trial shows that among obese patients, HMV once weekly subcutaneous injection of transaptide is superior to placebo in improving body weight and patient-oriented quality of life, including the cancer score and 6-minute walk distance. That landmark finding was basically there was reduction in the worsening heart failure events. There is reduction in HSCRP, which could represent a mechanism for the drug benefit. And in the sub-study, it showed that there is reduced LV mass and pericardial adipose tissue. So this was correlated with the weight loss.
So why you not took talk on STEP HF and why you choose this one?
So this was one of the talks in ACC guidelines of journal. This was new. And this was the only one which had some structural changes. They have done CM. We don't know how many images were adequate or not, but this is one study which has been published as somewhat CMR that in cardiac magnetic resonance we are seeing there is reduction in the adipose tissue structure.
If that is the case, then all those cardiac MRI
SGLT2 and mineral corticoids or not. So whether this is the effect of that drug also, we don't
We
know.
don't. So that is the first thing. Submit my limitation check. The patient is on anti.
As same ZGCT likely to be have beneficial
These
with
are same set
SGLT2
of
inhibitors and mineral corticoids also.
That
But
is
the
what we
point
are-
is, importantly, in the limitation, neither they self or you have mentioned this thing. One. Number two, what are the transthoracic echo criteria of increased LV filling pressures?
Transthoracic, one is LA enlargement, second is high.
How much?
LA enlargement is basically on LA index, LA enlargement by body surface area. So normally it is 34. Some of the studies says 24, but more than.
How much?
Sorry, 28. 28 to 34 is considered normal. More than 34.
28 you can consider for SN population if you want.
Yes. So more than 34 LVAI index is said as LA enlargement. So one is that. Second is high mitral high E by E dash velocity. So that is early mitral inflow velocity 2 divided by early annular mitral velocity. So that values are more than 0.8 is also
E
considered.
by A you are saying.
E by E dash. One
E
is
by E prime.
E prime, sorry.
Right?
E prime. So one is from normal pulse width Doppler. Second is tissue Doppler imaging. So both of those.
What is the cutoff for that?
0.8.
9?
8, more than 8.
Average E by E prime more than how much will give you high filling pressures?
I forgot.
15. Right? And if it is not E by E prime, then independently what is the tissue Doppler cutoff for mitral side and septal side E prime?
For my.
This is your last third criterion. What is the fourth one?
This is that. The fourth is coronary hypertension or diastolic MI.
Pulmonary hypertension is the derived parameter. What is the actual parameter that you check?
Regurgitation.
TRZ velocity.
TRZ.
What is, if not more than what, then it will call increased filling pressure. More than 2.8 meter per square, right? Meter square. પછી જે lateral E prime અને septal E prime નો cutoff શું છે?
Septal. 8 and 16. I forgot.
જોઈ લેજો, આગળ બધું